Welcome to the new DC Health and Wellness Center. This is the Department of Health's Sexual Health and TB Health program. We used to be on the campus at DC General Hospital, and now we have moved over to this location. So much appreciation to Mayor Bowser and Dr. Nesbitt, Dr. LaQuandra Nesbitt, for making this happen. My name is Michael Carfin. I'm the Senior Deputy Director for the HIV/AIDS, Hepatitis, STD, and TB Administration here in the DC Department of Health. I just want to say about our new DC Health and Wellness Center. We'll be offering health screenings, HIV and STD prevention, STD treatment, particular pre-exposure prophylaxis, which the Mayor and Dr. Nesbitt will be talking about. We've already enrolling persons on that program, and post-exposure prophylaxis, which is another HIV prevention strategy. Also, hepatitis screenings and care. We'll be offering hepatitis treatment here, sexual health counseling and education, reproductive health, and immunizations, and more. So we hope that you'll get the word out for us to have persons to be able, residents from the area, from the metropolitan area, to be able to use our program here. So without further ado, I would like to introduce the Mayor of the District of Columbia, Muriel Bowser.
Well, good morning, everybody. I am also pleased to be here with many friends and many colleagues and advocates who have been working with the District of Columbia to end the epidemic of HIV and AIDS for a lot of years. And on this World AIDS Day, as we did last year, we're able to talk about real progress in Washington, D.C., but also to lay out a bold plan. The plan that we talked about last year now has the real task and ways to get there to the goals that we've laid out for 2020. So I too would like to thank Michael Carfin, who has been a tremendous leader for us at the Department of Health. Give him a big round of applause. And Dr. Nesbitt, who is a hard charger, isn't she? Fantastic physician, a wonderful public administrator, and she has my great confidence in moving this work forward. I too want to thank my friend Walter Smith from DC Appleseed, who's been on the front lines for a lot of years. Thank you, Walter, for your tremendous help. Channing Wickham from the Washington AIDS Partnership. Thank you, Channing. As well as our friends at MAC, who have donated so much to making sure that we're fighting in multiple ways the AIDS and HIV epidemic. So Nancy, thank you for being here at MAC. You always want to check your makeup to make sure you're looking okay when Mac's in the, look how. So, let me just say this. Each December in Washington, we join the world and the nation in commemorating World AIDS Day. It was designated back in 1988, and this is the day where we raise awareness about HIV/AIDS and honor and remember those who have died as a result of AIDS and its related illnesses. We pay tribute to our friends and family and neighbors, and especially those heroes and heroines that never stopped hoping, fighting, and working for a better tomorrow, even knowing that they would probably not benefit from their own actions. So to all of them, we remember them, we acknowledge them, and we acknowledge the people that miss them dearly. And last year on World AIDS Day, I signed the HIV Fast Track Cities Declaration. This declaration is based on the UN AIDS goal that will have a profound impact on ending the HIV epidemic and includes a commitment to providing local leadership, fostering innovation, and promoting health equity. It is so important for all of us to recognize what cities can do, what mayors can do. And later on today, I'm going to Mexico City to talk about what cities and mayors can do to fight climate change. And so that's one thing we can never forget, especially as we face very uncertain times. We don't always know what's going to happen at the national level. We don't always know what the Congress can do, but we know the actions that we can take and must take to keep our own residents healthy. We will be sharing the latest statistics on HIV and hepatitis and STD and TB in the district. And we will be talking about exciting new public-private partnerships supported by the MAC AIDS Fund. So this year, I am grateful that you have joined us, where we will announce a new chapter in HIV and fighting the HIV epidemic in DC. And today, in partnership with DC Appleseed and the Washington AIDS Partnership, our 90-90-90-50 plan to end HIV in DC is fully fleshed out. This morning, I am also glad that we are holding this event in this new center. And so as Dr. Nesbitt was walking me through, she was talking about how we have the state-of-the-art equipment. We have a private facility where many people will feel more comfortable coming for treatment and testing. And we want to make sure everybody knows exactly where they are located in the center of Washington. So Dr. Nesbitt, thank you for your vision and making sure we got here. This is very important to our fight. So let me say a little bit more about what we talked about last year. We formed a public-private collaboration to prepare a plan for ending HIV epidemic in the district. We set an ambitious, but we believe achievable goal. 90-90-90-50 is what we call it. And here's what that means. 90% of all DC residents with HIV will know their status. 90% of the people will know their status. 90% of people diagnosed with HIV are on treatment. So 90% of people will be being treated. And 90% of persons on treatment will achieve a viral load suppression, which means that the HIV is undetectable. 90% of the people being treated will achieve viral load suppression, undetectable HIV. And 50%, we will achieve a 50% decrease in new HIV cases, and all by the year 2020. 90% of DC residents know their status. 90% of people with HIV being treated. 90% of people being treated will achieve viral load suppression, and we will decrease new cases by 50% by 2020. 90, 90, 90, 50. The plan contains new analysis on how we can calculate reaching those goals. So a goal without a plan is just going to be on the shelf. This plan contains 42 tasks and ways to achieve them. Let me highlight a few of the changes. We'll focus on increased testing, quicker connections, and initiation of treatment, improve support to help people get back on treatment who have fallen out of care. We'll expand access to PrEP, which Dr. Nesbitt will talk to you a little bit more about. And we, of course, are focused on things that we know help people, all people, maintain good health, and that's having stable housing. And we know when people have housing first, they can take care of a lot of things, including their health. So Dr. Nesbitt and Mr. Smith will share more of these details, but I wanted to be here to make sure that you know that we're on the path to getting there. I have a few more facts to share, and then I'm going to invite the experts up. For the 8th year in a row, we have seen a decrease in Washington, D.C. in new HIV cases. That's good news. 8 years going. In 2015, there were 371 new cases of HIV diagnosed and reported, a decrease of 48% from the 720 cases reported back in 2011. And I often look at things in the perspective of, when I joined the council and the work that we've been doing together, council members, mayors, since that time. And so that year was 2007. And in 2007, we had 1,333 new cases that year. So since 2011, in that 9 short years, we've had a 72% decrease in the number of new cases. The other thing that is so important to announce is that for another year, there were no babies born in Washington, D.C. with HIV for another year. And I'm also pleased to report that our effective needle exchange program continues to decrease newly diagnosed HIV cases that can be attributed to injection drug use. For example, we had 8 new cases in 2015, and this is a decrease of 95% from 2007, when we got the congressional ban on DC funding for needle exchange removed. I'll say that again. There was, remember when remember when the Congress wouldn't let us run our own program? And when we started running our own program for needle exchange using our own local dollars, we saw a 95% decrease in infection, new HIV infection related to injection drug use. 8 cases in 2015. So with our goal, what that means is by 2020, there will only be 4. Or why not make it 0? So that is the work that people here in this room have been doing long before 2007, and we can certainly trace it back to the first World AIDS Day in 1988. And so the district has also enjoyed, as I mentioned, a tremendous partnership with MAC, the Washington AIDS Partnership, and Appleseed throughout these years, and I couldn't be more delighted that their knowledge, expertise, and passion has been a part of this process. So while we're here and we've gathered a lot of experts, I also want to mention that every agency, it's not just the Department of Health whose responsibility it is to keep people healthy. 33,000 people work for the district government. I have 72 agencies, and I think they have a role to play too. And that's what we have to remind people each and every day. I'm pleased that we've been joined by Sheila Alexander Reed, who directs the mayor's office of LGBTQ affairs, and I want to thank Sheila for being here. But let me mention a few of our agencies that are out today also putting some of these efforts into action. We have a volunteer organization, the Mayor's Office of Volunteerism, called Serve DC, and they are, for example, participating in awareness events today at metro stations from Anacostia to Columbia Heights. They will be distributing bags with testing information, condoms, and resource guides that can help our residents. They will be holding a special food drive in coordination with Food and Friends, who of course serves many people living with HIV and AIDS in the District of Columbia. My Office on Latino Affairs is also conducting condom distribution efforts that, combined with resource guides, will help raise awareness about HIV and AIDS among traditionally disenfranchised populations. So let's get to work on our 90-90-90-50 plan, and by 2020 achieve their bold goals, but achievable goals. Thank you for being here.
Now I'd like to introduce Dr. LaQuandra Nesbitt, Director of the DC Department of Health.
Good morning, everyone. This is such an exciting day for us at the Department of Health, and such an exciting time for all of our community partners who have worked so diligently on this plan. The District of Columbia has been part of this fight to end the epidemic because we understand the tremendous impact it has on the lives of our residents. Not just our residents who are infected with HIV, but all of the loved ones they have who are also impacted by the virus, and the community organizations who serve them, the academic partners who are working day in and day out to find ways to cure HIV and also to prevent its transmission in the future. We thank Mayor Muriel Bowser for her tremendous leadership. It is indeed a pleasure to work for a mayor who has a commitment to health and wellness. You don't find leaders like that every day who absolutely get it. Who get what it means to have a community who is healthy and well and understands the connection between health and wellness and prosperity, economic prosperity, educational prosperity, financial prosperity, and what that means for a community to be able to thrive. What you will also see is that it manifests that way in all of our partnerships. We've had long-standing partnerships with DC Appleseed, and we want to thank Walter Smith and all of the law firms that are part of DC Appleseed's commitment to working with the Department of Health on the 90-90-90-50 plan. The same with Channing and the Washington AIDS Partnership. They have also brought such a variety of thoughts and perspectives to this partnership. But we also have some other partnerships, like the George Washington University Milken Institute of Public Health and Dr. Alan Greenspan and Dr. Amanda Castle, who have worked with us on the annual reports that we release and add significantly to the research enterprise here in the District of Columbia and have helped us leverage a tremendous amount of financial resources, but also intellectual resources to advance the science of understanding what has helped us to reduce some of the negative outcomes that we've had in the District of Columbia that the mayor has been able to share with you all today. But we also have a tremendous team at the Department of Health. So many of the staff that you will see throughout the day, and we hope you take a little bit of time to look at this new wellness center we have here, but the staff at the HIV, AIDS, Hepatitis, STD, and TB Administration, also known as HOSTA, work diligently and compassionately to make sure that we are not only advancing the evidence-based science, but also introducing promising practices and serving with compassion here in the District of Columbia, serving not only adults who are impacted, but also making sure we're listening attentively to the youth in our community and hearing what they have to say and making sure that we can end HIV in a generation, which is a plea that is made not only nationally, but globally. We also want to make sure that we're giving credit to President Obama's National HIV/AIDS strategy, the first ever in our country, which laid out a huge part of the framework for our plan and some of the other plans that have been replicated throughout the country. And we would be remiss without thanking the MAC Cosmetic AIDS Fund, which has been a huge partner for us in advancing the PrEP campaign. And you see some of that campaign posted here today, but you also have been able to see it on buses and bus dioramas throughout the District of Columbia, helping to reiterate the notion that PrEP should really be thought of and used in the heterosexual community as well, and it should be thought of as taking charge of your sexuality and your health and wellness, and making sure that we can reinforce that message throughout our community. Mayor Bowser has mentioned to you all the core tenets of the 90-90-90-50 plan, and that plan is available on the Department of Health's website, doh.dc.gov, so we invite you all to take a look there. We have some hard copies. We are a green city, so we want to make sure you all understand that. So we don't have several hard copies of the plan available. We'd like you to visit our website to see so many of the details. But It was definitely a collaborative effort with lots of ideas brought to the table, and we want to make sure that the plan is indeed actionable, achievable, but most importantly, measurable, so we can have some tools for accountability. We believe in being a transparent and accountable government, and we want to have accountability for our community partners who are going to be along this walk with us. We believe in implementing evidence-based practices, but we don't advance our society and we don't advance our community without leaving space for innovation and promising practices. And so we've left the opportunity for us to be able to do that in the plan. You'll be able to see through the plan that so many of the resources that we have to address HIV in the District of Columbia funnel through federal funding sources. But we aren't completely restrained in those federal funding sources. So you'll see innovative approaches there, such as taking new ways to think about how we use our HIV housing resources. We don't want to only use those resources to fund housing in a crisis, but thinking about creating financially sustainable plans for individuals who participate in the HOPWA program. Thinking about making capital investments as part of the mayor's commitment to affordable housing, to be able to invest in housing stock through the Department of Health, to build affordable housing for HIV-infected individuals to be able to participate in permanent supportive housing programs, but also for us to be able to invest in affordable housing in a meaningful and concerted way. So you'll see things like that in the program, in the plan. We've been able to do some tremendous things through healthcare transformation that have allowed us to be able to invest more strategically in social support services. We talk a lot about health equity and addressing the social determinants of health. And so we continue to have a focus on education and outreach, but we're also recognizing the importance of creating stable financial environments for individuals. So making investments in those types of things for individuals who are going to live well into their 70s or 80s with HIV as a chronic disease, and recognizing what we need to have in place for them with job training programs and things of that nature as part of the strategy as well. You will see that we recognize that some of our programs are regional. And because our programs are regional, we need to treat people as if they behave regionally. And so thinking about the programs in terms of portability of benefits and what that could mean for people remaining in care when you're not restricted about where you go for your care, and us being able to pay for that care as an insurance benefit as opposed to a restrictive grant that binds you to a single location. So if you moved from Ward 1, where not us restricting you to only being able to go back to Ward 1 to get that care, because it's more important to us that you remain in care. You continuously have access to your healthcare providers, your medications, because that viral suppression is more important to us for you not transmitting the virus to other individuals and keeping our HIV rates down than whether or not we can strategically micromanage a grant in a very old school type of way. So we're thinking very creatively about being patient and person-centered as opposed to being, how shall we say, bureaucratic-centric. So those things are very important to us, and we've listened to patients, we've listened to providers, and we're being very attentive to individuals. We recognize the importance of having constructive dialogue around decreasing stigma, how important it is to decrease stigma, recognize that being afraid to have conversations about HIV in communities is one of the things that keep HIV rates very high. So we have to be open to having those conversations, having conversations in safe spaces, but also being willing to have conversations in places that make people uncomfortable, because that's the only way we will eventually make them comfortable. So we recognize a commitment to decreasing stigma through this plan and thinking strategically about ways to do it. PrEP will be a cornerstone of this plan. And thinking about PrEP beyond the traditional way that a lot of people have thought about it. I've been in social settings since we started going through this plan, and I've had people tell me, well, we thought PrEP was only for the MSM population. I said, oh no, wait till you see our bus ads. And so people are really starting to get it. And we want people to know, even in this room, that people can come here and initiate PrEP treatment. And then we'll help to navigate people into the right clinical environments for them to continue that therapy. Overall, we'll need to treat more than 6,000 new people in DC every year for PrEP to be optimally effective. So we won't be able to manage all of that here. So a key part of our strategy is training more healthcare providers to be comfortable with initiating PrEP therapy. So that's an extremely important part of the plan. And as I mentioned before, the MAC AIDS Foundation is a critical partner for that success. I want to highlight three key features for the report. We analyzed our data and calculated the number of persons with HIV currently residing in DC. We include HIV, STDs, and hepatitis among transgender persons in our annual report. And we use the general term of sexual contact for HIV transmission to reduce stigma and misclassification of persons by gender. So these are the things that we're doing in an annual report that we will use to help us measure progress toward the 90-90-90-50 plan. Some of these classifications that we use that I just mentioned are unique to the District of Columbia. So you may have a hard time comparing our data to other jurisdictions' data, and for us, we think that's kind of a good thing because we're creating more classifications to help us better understand what happens in our LGBTQ population. We don't want to clump that population all into one. Because the way that we have to develop strategies to address specific subpopulations is different. You don't have the same strategies to address the lesbian population as the transgender population, and you don't have the same strategies to address the male to female transgender population as the female to male transgender population, right? And the types of sexual contact that people have is different for the risk for HIV. So we will present that data in our annual report in the most specific way possible to help us track our progress through this plan and help us think about the newest and most specific strategies we need to advance our progress. So just a little bit about where we are currently. We've started to be able to enhance our data collection methods in a way that we believe we have counted the total number of people currently living in the district who are HIV positive. And that number is at 13,391 current residents of the District of Columbia, which represents about 2% of our current population. The World Health Organization recognizes anything over 1%. But I do want to encourage you all that is progress, because at one point of time, as the mayor mentioned, we were at 3% or slightly higher of 3%. So we've made tremendous progress. I also want to be able to give you all some insight into where we are. The mayor gave you our 2015 number of 371, and our counts for 2016 so far preliminarily are at 188. So we are making progress that if at the rate that we currently have case counts coming in for 2016, we will be lower preliminarily in 2016 than we were for 2015. So we continue to make progress year over year in addressing this HIV epidemic. We also are responsible for STDs and decreasing STDs in the District of Columbia, and we have some positive news to share among youth and men in the District of Columbia, which have typically attributed to higher rates of STDs in our community. We have seen decreases in those populations as well. So that's other good news we have. I also will look forward to sharing with you all in the coming months for many of you who are engaged with us on HIV work, have been engaged with us in our newest efforts in hepatitis C, is that some of you know we had some significant progress or positive results with what's called the ASCEND study, which was a huge project we had with the NIH. Now we're going to be making some new announcements around some exciting work we're going to be doing in the area of hepatitis C, which actually can be cured. We do have a cure for that. So we're going to be looking forward to making some announcements for that in the future. So we are extremely excited about the 90-90-90-50 plan, actually having a plan with 42 tasks where we can be held accountable, where we can measure our progress, where that was truly a collaborative public-private partnership that all of you have bought into, and we look forward to being able to do other great things here in the District of Columbia and continuing to act in the best interest of our residents and being able to work toward the goal of ending the epidemic in the District of Columbia and working toward the global goal of ending HIV in a generation. So without further ado, I'll bring you Walter Smith, the Executive Director of DC Appleseed.
So good morning, everybody. I don't have anything prepared because I wanted to see what these other stunning people were going to say. I don't know if you know quite how remarkable what is happening today actually is. This is one of the strongest collaborative efforts I have ever seen, and I've been working on quite a few for quite some time. The district government and the nonprofit community and the community organizations and the law firms and the academic institutions and the funder community and the media have all come together in one common goal: to take on something really huge. And if you're not in this thing for the long haul, you're not going to be able to accomplish it. But given where we started, and a lot of you were here when we started, we came from a situation where the District of Columbia was setting a bad example for the nation. We all knew that where we were with regard to HIV/AIDS was absolutely unacceptable, and that the community, the whole community, and I include the government in that, had to come together to come up with a plan to address it. And you've heard from Dr. Nesbitt and the mayor how far we have come. We have come so far that with this plan today, we are on the verge of setting a different example for the nation, a good example for the nation. We are adopting something today that I think can become a model for other jurisdictions about how you end the epidemic. And we didn't think this up all by ourselves. It took input from everybody into what we're doing here. And I'd like to underscore something that Dr. Nesbitt said. The community has bought into this, and they need to, because without community input and buy-in and being every day on the lines to make this work, we're not going to achieve this thing. An easy part of what we're doing here is to write a plan. And not that it was easy, Michael. Actually making it work in the community is a more difficult thing. And without our on-the-line community partners being part of this effort every day, we're not going to make this happen. And I just want to cite one example of what's a really important feature of this plan that we learned from the community, and the mayor mentioned it. Stable housing. A lot of people don't understand how important social determinants are if we're actually going to achieve what we're talking about here. Stable housing is critical, and Dr. Nesbitt said we've got 43 tasks, and several of them are the stable housing component. So I just want to congratulate those of you who were part of this. If you weren't, I invite you in now. If you've been at this for a while, look how much you've achieved. And before I sit down, I just want to mention one other person who's entitled to a lot of recognition here, and that's Channing and the Washington AIDS Partnership. I've only been at this for 13 years. Channing's been at it much longer than that. The idea of the collaborative effort that DC Appleseed would be part of came from Channing. The idea that we had gotten to a point where we were ready to develop a plan to end HIV, I first heard about from Channing and urged me to bring other partners to the table, and that is what has happened. And since we've all been in this for the long haul, I think because there are now so many of us, I think the mayor referred to colleagues, friends, and advocates. We're all part of this now, and we're all going to benefit as we do this. So I congratulate the players. Please play on. If we're going to get to these lofty goals, we're going to need everybody invested. And I'm confident that's what's going to happen. And now I'm going to let Channing come to the podium.
So, this is an exciting day for the District of Columbia, and I'm honored to share this podium with Mayor Bowser, Dr. Nesbitt, Michael Carfin, Walter Smith, and Nancy Mann, and to share this room with so many of my friends and colleagues and heroes in this fight against HIV. So I'm overwhelmed to see all the faces around me who are, and the smiles and the friends. So thank you for being here. I've had the opportunity to lead the Washington AIDS Partnership for 23 years. Yes, I began as a teenager. And to say that I've seen a lot during that time would be a vast understatement. The changes in the district's response to HIV and the changes and improvements in the philanthropic level of support are truly astounding. When I first began this work, there was very little data about our epidemic. We didn't know where it was. There was a revolving door of leadership at HOSTA. In fact, the name HOSTA is probably the 5th name that has existed since I've started this work. So much has changed since then. It's remarkable. We understand now where the epidemic is. Our epidata is amazing. The level of philanthropic support is the envy of my colleagues around the country, and it's so exciting. We've become a national model, and the work that we're doing is really just beginning. And one thing I want to caution people about is that with all the good news we've heard today, other jurisdictions, countries around the world have also had good days and good times. And then things change when you lose focus on the goal. So despite the good news we're hearing about today, now is the time to double down. We can achieve these goals, but only if we increase our level of work, not in any way get complacent. I work in the philanthropic sector, and I know how rare it is for philanthropic partners to stay engaged and to make a major long-term commitment. MAC AIDS Fund has stood with the District of Columbia and has made some of the most innovative work possible, including introducing the female condom in DC, Positive Pathways, a program to employ peers to keep people with HIV in care, MORE, our mobile medical initiative where we provide HIV care in people's homes, and now our Prep for Women initiative. So I'm grateful for the support, and I'm happy to turn over this podium to Nancy Mann.
Thank you. What an amazing group of leaders. I mean, one of the things that we learn a lot in the for-profit sector is that leadership matters. And we have been lucky enough to be partnering with the UN on a Global Cities Initiative. And what we've been doing, we are giving $6.6 million globally. And one of the pieces I really just want to reinforce is the quality of the program here. I have a board of directors who are all business people who look not only at data, but look at results. And we are giving $1 million to Washington, D.C. out of $6.6 million. And we're doing that because of the quality of the business model. And because year in and year out, I can go back to my board and I can give them the results. And all of those results is not only leadership, but also the everyday leadership of everybody in the community. And one of the things I think we've also admired about Washington, D.C. is your ability to, in a very open, humble, loving way, embrace your community. And to meet people where they are. Part of the day I sell cosmetics, and I'll tell you that the customer is always right? And that's true in nonprofits too. And I think one of the mistakes that we've made in the HIV space, through no fault of anybody in this room, is we've been very finger wagging, and we haven't really made sex sexy or celebratory. And actually, I was feeling pretty good about going to the gym this morning until I looked at this one. I am not going to flex my arm. But I came in here and I thought, wow, who did this campaign? This is an amazing campaign, and it is so celebratory and so powerful. The other piece, honestly, is that we've kind of left women out of the epidemic in a very big way. And the fact that you have leadership talking about trans men and trans women, you guys are on this. And so our money is on you. We are lucky enough to raise money. One of the things that's nice about the work that we do is we've been at it for 25 years. When I started, people used to think I worked for Mac Computers. They'd be like, oh, you raised all that money selling computers and lipstick? I said, no, just lipstick, just lipstick. So that finally that we're known is terrific. But, the bottom line is the money is raised by our makeup artists. We have thousands of makeup artists in this city, whether it be in Union Station or in Chevy Chase. Go in and give them a hug if you believe in what we do. Sometimes it's not hard to sell products for people living with HIV. We have some customers who are super supportive. We have other people who are not super supportive. But it's an issue that we care about as a community. We have many trans makeup artists. We have many LGBT makeup artists. And we have the largest number of African-American women makeup artists of any company in the world. And we are proud of that. And they drive our company. And they obviously drive your incredible solutions here. And then the only other piece I just wanted to mention is we've been doing these announcements. Actually, we did Mexico City earlier in the week. So I give a shout out to Mexico City. But there is no city in the world where we've had both the mayor and the Department of Health, head of the Department of Health as a woman. So I think the fact that this is happening in this city and that this model is not just a model for the nation, but really is a model for the globe, really speaks again to your personal commitment, to your humility, to your leadership. And I love the term hard charging. So, God bless you all. You're doing a great job. And this city is really something to behold. So thank you very much. It's a privilege.
That ends our formal remarks, and now we're available to take any questions. Yes, sir.
I'm James Wright with the Afro-American newspaper. Has there been any engagement of African American churches? What is the role of the faith community, particularly the African American faith community, in this?
The answer is absolutely yes. We have continuous and ongoing engagement with the African American community, and specifically the African American faith-based community. So we had direct engagement with a variety of organizations and stakeholders specific to the 90-90-90-50 plan. So part of that direct engagement included all of our current grantees through HOSTA, through our current programs, and we have specific grants that go directly to African American faith-based organizations to target those communities.
Hi, Neil Lloyd, with WTOP. Can you please help explain a little bit about number 3, goal number 3 there? What sort of how the testing works, and just a little bit about the status that is achieved when with the suppression.
Okay, so I just want to clarify, the question is around the goal for 90% viral load suppression and how we determine that the viral load is suppressed. Mm-hmm. Okay. So the goal around viral load suppression is that there is evidence that the likelihood that an individual who is HIV positive transmit the virus to another individual is significantly reduced. I think the percentage is around, Michael, give 96%. Me the 96% is reduced by 96% if the individual is virally suppressed. So what we do with individuals who are HIV positive is we actually have tests that determine their viral viral load, which is the amount of HIV virus that is present in their system. When that test comes back undetectable, we consider them to have viral load suppression. And that test is done on a routine frequency for any individual who is HIV positive. So what we're looking for is for people who are in care, all of their test results come to the Department of Health through our surveillance programs, and so we're looking for that percentage to be 90%. If you look in our annual report, which is also available at doh.dc.gov, you can see where we are annually with HIV positive individuals who have viral load suppression. And so that's the number that we're tracking to be at 90%.
You mentioned the effort to educate or get the healthcare community to look at PrEP as a really serious option here. Are you still finding resistance among doctors or healthcare providers who are skeptical, concerned about possible not regular use of that drug and possible resistance and so forth?
We don't find that the skepticism is amongst the actual provider community. The skepticism might be more amongst us, I would say. And it's not really a skepticism in the way that you're using the word. What happens, HIV is a very smart virus, okay? It does something called mutate. So once an individual is HIV positive, if they start to take medications and they stop taking those medications, then the virus mutates and those medications no longer work. The concern with PrEP is that individuals, if they begin PrEP and they don't continue with the medication consistently, it can become an ineffective form of therapy for them and potentially become an ineffective therapy for greater portions of the population. So what has to happen is that we have to educate providers around identifying individuals who are appropriate for PrEP, meaning that they are likely to adhere to the medication. So when we speak about educating the provider community about the use of PrEP, we're talking about being able to screen individuals so that they are appropriate for the use of PrEP, meaning that they are in particular relationships for which PrEP would be appropriate for them, their likelihood of adherence is high, or you explain to them the need to take the medication consistently, etc. All of those risks around what happens when you don't take any antiretroviral medication consistently. So it's not an issue of whether or not health professionals are resistant to actually prescribing PrEP. There's also this way we think about treating certain health conditions in the health professional community, what we refer to as proficiency. So if you're a primary care provider and you have HIV positive patients, most primary care physicians would prefer to have 25 HIV patients in their practice in order to consider themselves expert in it or proficient in it, or otherwise they would refer their HIV positive patients to an infectious disease specialist and co-manage them. So we don't necessarily believe that PrEP has to be like that you have to have 25 PrEP patients in order to do PrEP. It's not the same level of complexity as managing HIV positive patients. So those are the types of education and outreach messages that our team here at HOSTA is doing to increase the number of healthcare providers who are proficient in the use of PrEP in our community. Oh yes, and PrEP has good insurance coverage, and so we want to make sure that they understand that that should not be a barrier for use as well. So that's also part of the outreach and education.
And in the way back there?
Yeah, sorry I can't see you, but
I can see you.
okay. So we know stigma is a big issue for education, and as I look at the posters here, I see something that doesn't really help address stigma. I don't see women of all colors, I don't see all ages on those posters. So I just hold that up as we need to do better, especially if the first goal is 90% of those with HIV are tested, know their status. That means you have to cast a huge net across this city to test medium risk, low risk, the stigmatizers as well as those stigmatized. Can you say what you're talking about sort of creatively, innovatively to really fundamentally change the testing system so that, self-testing can be used, it's reaching different pockets, better access, let's say someone's tested positive at home, that they have clean access to the confirmatory test, don't have to enter as if they're test naive.
Absolutely. So thank you. That's a great question. We use a number of marketing components and materials to address and reach the population. So we have a separate campaign that we run that's called Ask for the Test that uses a number of individuals and diverse representation or cross-section of the District of Columbia to address more specifically your question. What we chose for the Prep for Her, Dominate Your Sex Life campaign was targeted specifically to the African American heterosexual population because they are the second highest group for new cases in the District of Columbia. So we wanted to make sure that we had a campaign that was targeted specifically for them and to them as it related to the use of PrEP. So this one is specific to PrEP, not necessarily HIV testing. With HIV testing, we have had a long-running campaign that attempts to mainstream the use of HIV testing in all care settings. So we have a long-running campaign that makes sure that people can do HIV testing in emergency rooms, which a lot of jurisdictions don't necessarily have because they fear liability issues of being able to follow up with individuals who have a positive HIV test. We don't have that here in the District of Columbia. We want to make sure people understand it is appropriate to do a HIV test in a emergency room. We actually even provide some tests still to emergency rooms. We have large, long-running campaigns about testing anyone in a primary care setting, regardless of age, regardless of gender, regardless of race, because we understand that this can have has no boundaries in terms of race, socioeconomic status, gender, income, etc. And so we have sensitized our community here in the District of Columbia. We also have a CME requirement that every 2 years, every licensed physician, nurse practitioner, physician assistant in the District of Columbia must have at least 2 credits of three, the other one is 2, 3, including myself, who must do it before I renew my license in December at the end of this month, lest you be fined. You must have 3 credits of CME or CEUs, CME is specific to physicians, around HIV to make sure that all of our health professionals understand the newest technologies, the newest testing, all of those things related to their population. So for this, we are hitting every health professional, regardless of what your patient population, your patient demographics are like. If you are clinically active in the District of Columbia, you need to be aware that there are folks who could be walking into your doors who could be at risk for being HIV positive. Thank you, everybody. Thank you.
Thank you very much.
Thank you, Muriel.